South Africa commemorates 16 days of activism against GBV. The World Health Organization has identified it as a public health problem. According to the World Bank, the rate at which South African women are murdered by their partners is 5 times higher than the global average. Joining us is Dr. Sizeka Mayewa, acting chairperson of the South African Medical Association. Doc, good to speak to you this evening. Now, something that the WHO has said is that GBV has been declared to be a major health problem due to its far-reaching effects. What are those far-reaching effects that the WHO speaks of?
Yeah, the far-reaching effects of GBV is the injuries which is caused to the victims, and also the services that they will actually need, which sometimes they even end up being killed, as depending on the perpetrator. So those are actually very serious issues. And as doctors, we are the first contact of all these GBV atrocities, which are being actually, which the public or the partner, whoever it is, it's actually causing to another partner. So at the end, those far-reaching effects have got a very serious impact psychologically and physically to the victim as well.
Now, the World Bank says that South African women are murdered by their partners and that this murder rate is 5 times higher than the global average. So it also suggests that the number of individuals that you are having to examine as medical practitioners is extremely high.
Yes, that is very true. And then for the fact that it's extremely high, you'll find that it takes time also, because you also have to collect some of the things like if it's a sexual assault, you have to actually collect some evidence, and then they must be tested somewhere, and all these other things, especially even the DNA. And it takes quite a long time to convict these criminals or even the partners themselves, because sometimes you realize that not in the long past, they remember there was a gentleman who went to a health establishment. It was Tembisa Hospital, if you collect your memory well, whereby the partner actually just take out a gun and kill the person, the partner in the workplace. So it puts a lot of health professionals in a very serious predicament. Also, some of our doctors, our female doctors as well, not necessarily from partners, you find that some of the patients come into the hospitals with guns, and then it really threatens everybody, and we are forced to really look after this person. It's not only for the partners only, but also healthcare workers are also in the brunt of being actually abused by the patients themselves, let alone the partners, because they are intimate. And some of the partners, we usually call it intimate partner violence, because it's also those who are not intimate, but there are those who are intimate, which is actually partners, in this case pertaining to a question.
Now, Doc, you've been in the business a long time, but you obviously have your junior colleagues that either have only recently qualified or have qualified a few years ago. Now, let's talk about their ability to deal with some of these situations, particularly when you speak of individuals who are perpetrators of crime, potentially bring in their partners to health practitioner to get looked at, but they have guns and they have other weapons that might be threatening.
Yes, the issue, you are very right, Hugo. The issue is that most of the junior doctors, remember, they are young. We are old. We have been in the profession for too long, and then we are also old. So it's easy for us to navigate around a situation like that. So usually the young ones, they usually become so scared that they can't even touch the patient, because normally what you realize is that when the partner comes with, when the perpetrator, who is the partner at this instance, come with the partner who's a female, what happens is that they actually are the ones who are supposed to talk. So we usually tell our junior doctors to say, in most cases, ask the partner to go out, because the victim might not be free to express exactly what happened. And we realize that it's a lot of navigation around the issue to say the experience also counts, but also we have to be with them as juniors, as seniors, and then to take their hand to understand how everything is done, because it's not easy. They sometimes become even violent to say, why do you chase me out of, this is my wife, or this is my girlfriend? Why do you chase me out of the consulting room if you want to talk to her? You cannot talk to her in my absence. So we have got a way of actually trying to negotiate with them. Fortunately enough, also police, they are a paramount help, because they come with, we usually call the police to come and be present, because it's our duty as healthcare professionals to report this kind of violence, especially from the other partner, like I called it, intimate partner violence. But indeed, our junior doctors become so scared that they don't know what to do. However, we as seniors, we usually sit around with them and then go through all these emotions, because there's a lot of psychology involved when you are dealing with people of that nature, because they are violent by themselves.
But we must hasten to talk about the psychosocial support. Obviously, the victims, clearly, they need a huge amount of that. But let's also talk about the health practitioners, because where the rates of GBV that we speak of in South Africa, characterized by the murders, which are 5 times higher than the global average, must mean that most health practitioners, most doctors, at some point experience or have to deal with this continually. Just how much support do they get to deal with the trauma that they experience? I mean, you're a young doctor, for instance, and you're having to deal with the trauma of a victim being bruised or badly injured, and her partner has a gun in his hand or a weapon in his hand.
Yeah, what usually happens in instances of that nature, you may find that maybe the patient is very much injured. So what we do is, as much as the patient will also need what we call multidisciplinary approach, meaning there will be psychologists, social workers, doctors, and everybody else who actually is involved in taking care of even community healthcare workers, so that these people, they be discharged to the community. However, with the doctors as well, and all health professionals dealing with the situation, because they usually come in our casualty area, there is, after everything else has been done, the patient has been stabilized, everybody is actually comfortable, that the patient is comfortable as well. We do what we call debriefing. Debriefing means that we sit down and say amongst ourselves as a team to say what went wrong, what went right, what can be done correctly, what can be avoided. So in that score, we also have to give that psychological support. Usually we ask the psychologist to be, it's like a teamwork, that multidisciplinary, but usually the psychologist, we debrief the healthcare professionals, all of them, including even the nurses and everybody else who was involved. You must also remember, it's not only doctors only. We say healthcare workers, the radiographers who have to take the x-rays, even the nurses who have to actually put up, which we help each other together with the doctor. So it's a team. We sit down after everything and say, let's debrief each other and cancel each. There will be those who need more intervention than that debriefing. Then there is a continuous interventions to them.
Now, Dr. Sizeka, why do many cases of GBV go unnoticed and unreported? And how does the existing social stigma and taboos contribute to this underreporting?
Yes, the issue is, like I said already, that you find that the perpetrator is the one who actually, sometimes what happens in real practice, what we see in the hospitals, you find that the person maybe is brought by the partner or by a relative or by a friend. What happens is that you find that this is a breadwinner. You find that the lady or the victim is not working. She's dependent solely on this person. She might also be having other children who actually needs the care. So they usually not, they'll actually try even to protect the victim and say, no, he actually is a sign of love and all those other things. Sometimes they don't even tell you, but you can tell that this is not something that they will tell you, no, I've just fallen, I was doing this and that. But as healthcare practitioners, we are trained to see what is, bruises at the back. How can you actually fall on your face and get a bruise at the back? It's not normal. So we usually sit down with them and say, I'm duty bound to report this GBV as long as I suspect it as a healthcare professional, because most of them, they'll want to protect this partner because they are economically dependent on this person.
Now, when these individuals come through and you look at them and you do the various assessments, do you often find that sometimes it's not just the victim himself or herself that comes into the hospital, that potentially it could be even the children that are feeling the pain or the impact of this abuse?
Yes, depending on the nature of the injury that the patient has gone through. If it's usually physical, you may find that the children maybe they are left at home or left with some other people. They don't come with children. But during that multidisciplinary, we usually involved in what we call a family conference. Then we'll call the family, everybody involved, the children and everyone else, even the perpetrator himself, to say, this is the situation. How do we help the family? What we call family counseling. We don't only, because the children as well, it impacts on them psychologically. Actually, you'll even find that the child is not performing well at school. Sometimes we'll even isolate the children and say, let's talk to them if they can be able to talk alone, because they can tell you what is going on in the family setup. So usually they will never come. Usually they won't come with the children. What I'm trying to say is, we'll have, as healthcare professionals, in that multidisciplinary, we do what we call a family conference. So we actually ask the children to be brought in for counseling as well.
Now, there has been talk on a need for comprehensive support, right? So let's speak about what is this comprehensive support for GBV survivors, and what are the emotional and psychological challenges they face?
Yeah, the comprehensive support means that despite you treating the physical injuries that you see, you must also treat, in our medical terms, there is what we call it a 3-stage assessment. You look at the clinical issues, you treat the injuries, which is easy to treat if the patient is not killed or is not that badly injured. And then there will be those individual issues. Now we go into each and individual aspect to actually find out their concerns, their expectations, and all those other things, and ideas about the whole thing. What do they think? Why do you think that your partner is actually abusing you? What is happening in the family setup? And then we go to the contextual issues. Contextual meaning the environment where they live in, everybody involved. So the management, the management of these situations, it must be comprehensive. It must not only include taking care of the physical injuries, the psychological aspects where will come in the individual, because they will tell you what is the psychological impact of these injuries, or even the way they are being treated in their home state. So comprehensively, you mustn't only look at the injuries. So we actually say, let's do what we call a comprehensive management of this patient, rather than looking only at the physical aspects.
Dr. Sizeka Mayewa, Acting Chairperson of the South African Medical Association, appreciate your time this evening.